work, we live, we innovate, and create. At the center of it all is your brain health. The ability to solve problems, think analytically, share empathy, and thrive.
We're trying to make brain performance really the next fitness revolution.
Scientific discoveries show that your brain can adapt and grow regardless of your starting point. The Center for Brain Health can show you how to transform your mind to work stronger and faster.
We learned from a national poll that 95% of people want to do something about their brains. The problem is they don't know where or how to start. At the Center for Brain Health, we have easy-to-use, scientifically proven tools to provide people a proactive path to do just that, to help people everywhere improve their quality of life through brain health. What's exciting is that it's easy to start, and starting is urgent because we are in a brain health crisis.
So how do you boost your brain power? How can better brain health help you focus on what's most important?
Brain training is a part of the way that we would distinguish ourselves from others. Quite frankly, I think it's going to be commonplace in businesses in years to come.
We are seeing an epidemic of mental health concerns. Stress and overload lead to depression, anxiety, and burnout. Our brains hold the key to navigate these hurdles. It's never too soon to start.
I think the greatest national security threat is pre-K through 12. If we don't take care of educating our young men and women, then we have to ask ourselves, where are we going to be in 20 years?
Research shows training middle schoolers how to think, problem solve, and innovate significantly improves academic achievement. Even more importantly, it enhances confidence and well-being for them to thrive throughout their lives.
It really helps the kid and it builds their stamina. I genuinely credit my success in the classroom from this program.
The key to the future is stronger brain health for individuals and communities. Ready to transform the world with us? Be a part of the brain health revolution. It starts here.
I always underestimate how long that piano plays at the end. So I sit here and look kind of silly for a few seconds. Listen, welcome to Center for Brain Health. Thanks to everybody here for making the trip through traffic to be here. Thanks to the virtual audience for being online. We're kicking off our 2023 BrainHealth Presents tonight, and we couldn't be happier. We have a great lineup of speakers, and it starts off with a bang with Dr. Tom Insel. He is one of the most thoughtful and credible experts in mental health in the world, and I'll tell you a little bit about him and you'll see why that is. Tom is a psychiatrist and a neuroscientist, and as a former director of the National Institute of Mental Health, you may have heard of that, he is one of the country's foremost thought leaders in mental health policy. And in a conversation we had earlier, he's also doing some other cool new things, which you'll hear about in the talk. His work in the public and private sectors gives him a unique perspective on this really tough challenge, right? It's been a challenge. He'll acknowledge that as well. And he recently wrote a book, I recommend you read it, with new ideas for a better way forward. It's called Healing, Our Path from Mental Illness to Mental Health. So please look that up. And before we start tonight, a few housekeeping rules. First, as you saw in the video, we are a non-for-profit. So we're dedicated to enhancing your brain, keeping your brains healthier longer. That's a pretty laudable goal. And we can't do it without your help. And we couldn't do tonight without help from the Container Store, our sponsor tonight. So Satish and team, where are y'all? Thank you. Awesome. Thank you. And we're our friends at KERA. KERA is the public health station here in north central Texas. They're our exclusive sponsor. And who else do I need to thank? So this is a sobering reminder. Tonight is about mental health. So please, this isn't going to be a clinical discussion, and we're not giving help. But if you in the audience, if anyone knows someone who needs help, or if you need help and it's a crisis, please dial 988, right? Do not wait. So please do that. We're going to reserve the last 10 or 15 minutes for questions from the audience, both live and virtual. So we'll make time for that. And last but not least, today is day 4 of our first annual Brain Health Week. We've had over 200 people in this building every day this week, and no exception tonight, so thank you all for that. We're really excited, and you can learn more on brainhealthweek.org. I'll shut up in a second. And now I'd like to introduce Dr. Sandy Chapman. And Dr. Chapman, her resume is about this long, but all I need to say is Dr. Chapman founded this entire center. These 2 buildings you see, she built with her own 2 shoulders, and the rest is kind of history. So.
What better way to celebrate the first day than being here tonight with Dr. Insel? Thank you for that, too. Because I'm so excited about this. We were actually on a panel together in D.C. in 2017 on brain futures. What is the future of where we're going? And he was speaking about his new company at the time, and I was talking about the Brain Health Project. What can we do? How can we come up with an index, and what can we do? But I never thought that I would get to be in the same room. And you can, those of you that know me well, know that I have been working hard on him being part of what we are. So, he knows that already, I hope. But what I wanted to start with is I think all of us know coming out of the pandemic, these times you don't meet a person today, Tom, that hasn't been impacted because of the pandemic. Loneliness, isolation, loss, grief, pain. And it's almost just taken over a dark cloud of us. But for me, when I see so much that needs to be changed, I think, let's go. This is the best time possible to revisit and change up and change the conversation, especially toward mental health. I would love for you to talk to us because you are, I love that at one point were you the nation's psychiatrist that they call? Can you imagine? That would be a heavy burden. And I think about someone who carries the tears of the nation on his shoulder, that cares so much. And actually, when he left being the nation's psychiatrist, he really saw that he could do so much more than he ever did. And it was really a heart thing that made me drawn to your work. But talk to us about how your road for the last 50 years, you've been touched by mental health from a family member, from a doctor, scientist, and from tears. But tell us a little bit about your journey.
Oh, man. So I don't actually like to talk about myself, but I will do this for a little while. Because it's been weird and nonlinear. I have spent much of my life trying to figure out what I want to do when I grow up. And so now that I'm in my 70s, I guess I don't have a lot more time to do that. I got to figure it out pretty soon. But I started off, I did train in psychiatry and left pretty quickly because I just, at that point in the early 1980s, it wasn't that interesting to me. It was the beginning of the biological revolution, which was kind of cool, but the biology wasn't great and the psychology wasn't that sophisticated. It all got much, much better in the following decade, but I decided to go into neuroscience, and so I left the field and just retrained and started all over again as a basic neuroscientist. So I worked for about 20-some years at a bench at a laboratory, trying to understand how the brain works for complex social behaviors. Like it became really, actually, apropos of the situation you're in today, I was just totally shaken when my first child was born. And I felt like I had gone through like the equivalent of puberty. It was like a life-changing experience. I was in my early 20s, and I just like fell deeply in love. And I began to think that this was more than just psychological. I wanted to know what was happening in the brain. how did all that happen? And so I spent 20 years trying to understand the biology of parental care and parental behavior and love and attachment behavior. And we came up with studies of a set of neuropeptides, oxytocin and vasopressin and some of the opiates, and did a lot of the fundamental work to try to figure out how they work, where they work in the brain, what do they actually do? And it was a wonderful period to try to understand all that. 20-some years in, I got pulled back into psychiatry to run the NIMH. It was the beginning of the Bush presidency. There was a real interest in having an NIMH director who was interested in neuroscience and not just sort of a traditional clinical psychiatrist. And so having been away for 20 years, I came back. And kind of like Rip Van Winkle, because what was amazing to me was nothing had changed very much. I had been kind of in the, really the vanguard of a revolution in neuroscience and how we study the brain and how we think about the brain. So much changed between 1980 and 2002, which is when that happened. It was a different field, and it was really an exciting time. But in clinical care, we had more medications, but I couldn't really see that we were making a lot of progress. And so it was, for me, the challenge was, how do you take that revolution in neuroscience and bring it into mental health? How do you go from mental health to brain health, basically, and marry those two? And it was, again, a great run. I had, 13 years through those two administrations, Bush and Obama. And it was a real privilege to be able to work in the federal government at that level. I think we did a lot, but just at the end, around 2015, when I was trying to decide what I wanted to do next, I was in a, actually it was a place very much like this. I think it was in Oregon though, but it was with a group of family members and sort of a general public audience. And I was talking about all the great things we had done through research. I had these fantastic brain images and stem cell work and all with the things we were doing with genetics and epigenetics. And at the end, during the Q&A, someone got up. The first question actually was a guy got up and said, "Man, you just don't get it." What? He said, "Look, I have a son who's 24 years old, and he has schizophrenia, and he's been hospitalized 5 times, incarcerated 4 times, made 2 suicide attempts, and he's currently homeless. Our house is on fire, and you're talking about the chemistry of the paint." And that was a real wake-up call for me, because on the one hand, I was pretty defensive. The first thing I said was, well, research is a marathon, it's not a sprint, it takes time. But the more I thought about it, it's like, he was right. And his follow-up question is, what are you going to do to put out the fire? What are you going to do in the short run? Because everything you're talking about might help somebody in 30 or 40 years, but we got a forest fire right now. And that was 2015, it's much worse. And Sandy, as you were saying, with the pandemic, what was already becoming a greater and greater problem really hit a crisis point. Some of you may have seen last week, the CDC came out with new numbers from this survey they do on youth mental health, or actually a whole series of sort of risk factors in youth. And it's just stunning. They were reporting that 57% of high school girls report severe levels of hopelessness and depression. 57%, 26% of them, I think, have thoughts of suicide, including making a plan, and about 12% of them have made an attempt. It's just stunning. And those numbers are all way up from where they were using the same survey in 2011. So yeah, things have gotten much, much worse. So I've spent the last 7 years since leaving the government in the private sector in startups. It's first in Silicon Valley at Google, and then at a bunch of new companies, trying to figure out how do we do this in a way that's different? And what can we do? How do we innovate to fix a problem that is just getting worse and worse? No matter how much money we spend, no matter what we try, we're just not making a dent. And my hope is that by bringing public and private efforts together, kind of like what we did with COVID, we might be able to actually make some of this happen. So that's what I'm deeply involved with right now. The book is trying to capture a bunch of that, because the book was really written when I was trying to figure out what went wrong here? Why did we not do better with all the things that, we spent a lot of money on research, we're spending a lot of money in care. Why are the outcomes so bad? And that's what that's why I wrote the book, because I was just trying to understand it for myself.
And I would say everyone in this room needs to buy the book. And Tara Bang has it for us, ordered on Amazon. If you were to see mine, it has pinky notes everywhere and pinch pages, but it is something that really will give you some ideas on where we should go and what we should do. So you've talked about this crisis, but one of the other things you say in your book that's really interesting is you say it's not a mental illness crisis, it's a crisis of mental health care. So it's the care that's the crisis. So even when you're talking about the youth and there's so much going on, it's really that the care isn't there. Can you talk to us about, especially for the youth, so when we hear this, we know our future is our youth, what can we do to make the care, if it's the crisis is there and we're hearing these painful things, then how are we going to help the crisis of care?
Right, yeah. Now, I knew you were going to ask me hard questions. So it's good to sort of break this down a little bit, because there's really three different problems that we're dealing with at the same time. One is this youth mental health problem, which is largely, in the last decade, much worse now. There's another problem, which I'll call the serious mental illness problem. It's a problem for people who have schizophrenia, schizoaffective disorder, severe depression, bipolar disorder, major mental illnesses that contribute to disability. And that is really at a crisis point as well. But not because it's more common or it's worse off. That's really the crisis of care. The prevalence of those disorders really hasn't changed much in the last 3 or 4 decades, probably not in the last 3,000 or 4,000 years, as far as we know. But the outcomes have gotten much worse in the last 3 decades. So people are far more likely to be incarcerated or homeless than they were when I started in my career. So what I was saying in the book is that there are not very many areas of medicine where you'd say, wow, it was a lot better in 1980 than it is today. But in this case, actually, we did better. I mean, people who have those illnesses generally did not become homeless, and they generally were not incarcerated in those days, and today they are. And that's just a profound injustice that we have to address. And that's sort of the crisis of care. And then there's a third bucket, so youth mental health, serious mental illness, and the third bucket is the substance use disorder crisis. And that's a different problem altogether. Very high mortality, over 100,000 people a year dying from overdoses. A lot of that is driven by the advent, of course, of fentanyl, which is far more lethal than any other substance that's ever been out on the street. A colleague of mine pointed out recently that the days of recreational drug use are over. Today, even a first dose of a drug used recreationally can be fatal, and often is. So this is becoming the largest source of mortality. And in fact, when you put these together, suicide, which is on the rise slightly, and drug overdoses, we call these deaths of despair. And I point out that during COVID, where we've mobilized the nation around the greatest pandemic since 1918, it is true that we lost 1 million people, about 1.1 million people in the 3 years of the pandemic. The vast majority of them are over 65. And if you look during those 3 years at mortality statistics, for people under the age of 30, there were 8,000 150 deaths from COVID, 8,100, maybe 8,200 deaths from COVID. In that same period of time, there were 140,000 deaths of despair in that age group. So yes, COVID was a massive pandemic, but during these 3 years, what we haven't really talked much about is for young people, for people under the age of 30, the group that is in fact our future. I call them the COVID generation. They are dying at an unprecedented rate from deaths of despair. Those numbers, that number of 140,000 over 3 years is just extraordinary. And if we weren't having a viral pandemic, absolutely this would be the topic that everybody would be focusing on.
That is really, I mean, I think we feel it, we hear it, we see it. And so for us, one of the things that you say also is that mental health problems are medical, but the solutions are not necessarily just medical. They're social, they're environmental, they're political, and maybe even spiritual. If the problems are medical and the solutions are so diverse, and you talk about this despair of deaths of despair, how can we bring the solutions to these younger people that can help this situation?
Yeah, so this really is back to the first question about what do you do? And it's actually part of the answer to the question I was asking in the book, which is like, why have we failed here? Why haven't we done better? We got a lot of people working really hard, and they're really smart, and they're doing a lot of good things, but why is it getting worse and worse? And some of that, you could say, well, the problem is the conditions are getting worse and worse. That's probably true, because we have greater problems with housing, and there are a bunch of issues that one can focus on. But what I came around to thinking, kind of, leading to your question, is that we've got the wrong model here, It's like we went to war with the wrong army or something like that, or we're fighting the wrong war. We've been treating this set of problems a little bit like they're infectious diseases, and that if we just can get the right medicine at the right dose at the right time, it'll take care of the problem. And I began to realize that that's probably not the right way to think about this. This is coming from somebody who, in 13 years at NIMH, I was all about neuroscience and getting new medications and getting the biology right. I spent a year working for Governor Newsom, kind of as his eyes and ears in California, and so I traveled the state extensively in 2019, and trying to figure this out, because in California we spend a ton of money on mental illness, and we have really bad outcomes. So I was in Los Angeles on Skid Row, and I was talking to a psychiatrist who's like what we call a street psychiatrist, who works on Skid Row with people who are homeless and often drug addicted and very often psychotic because they're off their medication. And his job is to get people on meds and things like that. And I said to him, John, I'm getting this sense that we've got the wrong model here. The medical model isn't working, that we need sort of a recovery model. And he said, yeah, that's right. He said, that's exactly what we need to do, is we need to think about recovery. And I said, well, what is that? How do you think about recovery? And he said, oh, man, it's easy. It's just the 3 Ps. And I thought, like, you got Prozac and Paxil. And I was thinking, like, what's the 3rd P? And I thought, well, psychotherapy, that's a P, right? And he just he shook his head and he said, it's people, place, and purpose. The issue here is that the medical model isn't addressing any of those things. And if we want these people to recover, we've got to think about people, place, and purpose. And so, Sandy, to your question, I think for young people as well, it's not just getting them on a stimulant, or Ritalin, or one of the ADHD treatments. It's not just getting them Prozac or Paxil. I think the question really is, how do we attend to those 3 Ps? Like what is it going to mean to be able to give them social support, so this connectivity? And we keep hearing that this Instagram generation is the loneliest ever, and in spite of the fact that they all have a gazillion contacts on the internet and through social media, they're incredibly lonely, and somehow that makes it worse. So that first P is to have relationships that are meaningful. The second P is place, is having an environment, and that includes everything from nutrition to what you're exposed to every day, literally your physical environment. And in the case of what we work with in my company, it's often just housing, getting people stable housing and getting them through food insecurity. I mean, really basic needs. And then the third piece, which is the third P, which is really the one that we never talk about in the medical model, and I think is probably the most vital, is purpose. There was, years ago, when I was in training, there was a really interesting psychiatrist named Viktor Frankl, who was a survivor of the Holocaust. And he wrote a book called Man's Search for Meaning. It's kind of sexist, that title, but anyway, at the time it went through. And the argument that he had was that if you had a why, you could live with almost any how or what. That having a why, having something that you care about. And what strikes me for a lot of what we hear about with youth and a lot of what kids are struggling with is it's that third P that they're often missing. They just don't have that sense of purpose. That some of that comes with the territory of being an adolescent, but it doesn't have to. And I think that's where there's really an opportunity, which is, of course, this is my cue to ask you about what you're doing in schools, because I do think that one of the places that we have to go here, if we want to really move upstream and get ahead of a lot of this crisis, it's not just, keeping people out of the hospital and keeping them into, getting them into clinics. It's also starting at the root causes and helping build resilience and helping to teach the next generation the things they need to know to cope in a world that's very different. So doing that in the school system, I think, is like one of the most exciting things we could be talking about now. And I know you guys are doing that here, but I don't know enough. So could you just unpack that a little bit? Because I think that's pretty cool.
And probably everyone here knows I'm dying to talk, because I'm just like, now you can see why. Why, when he talks about purpose. So, one of the things that we're doing here and that we've worked on for the last 3 decades is finding an index of what it means to flourish. And while I first started off with cognitive health, we've moved the definition of what it means to have cognitive health out of thinking of IQ or intellectual function to possibility thinking, someone that can really see things in a different ways. And when we worked with a lot of people that were in under-resourced communities or a military that had no education, man, they were wicked smart, because they could figure out solutions. This possibility thinking was something that really engaged the brain. And then the other area that helps people to flourish is what we call connectedness, which is your people. You've got to have people that are healthy relationships that you can rely on, and purpose. And when people have a single purpose, it makes them thrive, even if they don't have clarity. Or, it helps them to do things. And then calm. So mine are the 3 C's. Yeah. As you said, the 3 P's is clarity, connection, and emotional balance, because everyone has adversity. And one of the things that I'm curious that I want you to address is we approach everything from a proactive perspective versus what disease do you have. And that's why I got interested in brain health 3.5 decades ago, because I was a great diagnostician. I could diagnose autism, dyslexia, mental health, whatever it was, but it never made people better. And I saw that there were ways that people could get better, and the diagnosis didn't help them. So I wanted to know, what does it mean to flourish wherever you start? And can that be the engine that helps you to survive even in the worst of circumstances? So my question back to you is, yes, we're working with middle schoolers, training them how to think. And this really surprised us. This last year, we have a paper under review right now. We showed that youth in the worst of circumstances, not only did they learn that they could create new knowledge and innovate, but their stress and anxiety and depression significantly diminished because they used their brain and realized, I'm okay. I can make it in school. It's not like everywhere I'm a failure. And when they went home, they began to see the possibilities differently. And we've done it with the military. So my question back to you is, and it comes from our military experience, is we've worked with special ops, Marines, Army, Navy, Air Force, and what they said was, it seems like we have become victimized by mental health. We get baskets of drugs, we get all sorts of diagnoses, but we don't get the toolkit to make our lives better. And when we came to do some of the training here, we got some of the toolkit to work with both and. So can you talk about, and one of them in particular said, I don't want to be a victim, I want to be a victor and realize every single day there's steps I can take to make my life better. So can you talk to me a little bit about how you think our system in some way victimizes people versus gives some self-agency to maybe make small steps every day?
Wow. Yeah, I mean, so I think the thing to recognize is the system. So healthcare in the United States is just a business. You got to know that, right? It's a little different in Europe, but here it's simply a business with a P&L that you've got to explain. And what the system we have is a system we pay for. It's a system we incentivize. So it's essentially not a health care system, it's a sick care system. That is, you get paid when somebody's ill and they come for treatment. And so you're incentivized to have clinics and hospitals. To be really concrete about this, if you wanted to do the kinds of things you're talking about, where you're providing preventive care, like in a school, you can't bill unless there's a diagnosis. You have to have what's called the CPT code in the fee-for-service world of healthcare to be able to get paid, to get reimbursed. You can't send in a bill on somebody who doesn't have a diagnostic code for treatment. So, and that's what happens every time you go to your primary care doc. They may talk to you about other things, but what they're going to get reimbursed for is whatever diagnosis they can put down and whatever procedure they can do. That's how healthcare in America works. It doesn't work that way in the UK and in other places, but here it does. So it becomes really difficult to do what you want to do, which is to actually incentivize people to keep everybody healthy, or to move into the school system and provide the same kinds of things we do for physical health, for mental health. Talk about brain fitness, talk about resilience, teaching kids how to, as we say, you name it to tame it, teaching them about emotion, and also teaching them about even how to provide social support, all of those things. There's a whole bunch of things that are just useful skills. There's nothing particularly fancy about this. It's just like learning physical skills, learning how to kick a soccer ball. This is the same stuff, except here it has to do with how you think and how you behave and how you feel, and learning to manage all of that. But there's no way, we know how to do it, there's just no way to pay for it right now in many, many states or many communities. And it certainly isn't seen as part of the healthcare system's responsibility because there's no diagnosis. So you're right, I think we're going to have to, if we really want to get ahead of this, and we want to start making the world we want, because I don't think anybody really likes the world we're in. Maybe if you're a health insurer, it's a pretty good deal. But for providers and patients and families, it's not that great right now. We're going to have to figure out a way to move upstream and to begin to provide that kind of, I don't know if you want to call it preemptive or preventive or some other kind of care. We can do it if it's a vaccine. So you can get reimbursed for giving a vaccination, but not for teaching motivational interviewing to an 8th grader.
So our joint friend, Dr. Jeff Ling, often challenges us to get left of boom, what he calls it, where boom is when you get a diagnosis, but most of our lives we're in a healthy state. And if we can change the conversation to really help people know and give them the tools to do something to keep moving the needle forward, what do you see besides schools? Where else? You were talking about something in the workplace. Where do you see where we can really start building capacity where people can do things, whatever, even when they're in the worst of circumstances like Viktor Frankl or some of our youth, if it's themselves that they can make better every single day, how can we get there left to boom before something happens?
I don't think it's that mysterious. I think you meet people where they are. And if you're under, I was going to say if you're under 30, probably if you're under 50, you're on the internet. You're in social media a lot. And if you're under 20, you're spending 6 to 8 hours a day, either gaming or on social media. So that's where people are. Right now, that's a toxic soup, but it doesn't have to be. I mean, you could imagine that becomes the most powerful place to be able to build support. My previous company, Humanest, has just done that in spades. They work on filtering people through social media. That's how they pick them up. But then they create these small groups and they provide a set of tools for students to support each other. So again, they're sort of going after the 3 Ps in a way, with connection and with, in that case, they're not doing as much on the second P on place, but certainly purpose. And one of the things we've learned from that experience with Humanest is that when you talk to college students who are really struggling and who've benefited, and you say, what was really helpful? I mean, what did you hear, what did you learn that gave you help? They always say the same thing, which is surprising me. They said, oh, no, like, this was fantastic, but it wasn't that I got help. You gave me the chance to give help. You gave me that purpose. You gave me a chance to help somebody else. That's the most therapeutic thing I've ever done. And so the healthcare system does not do that. I guess it does it for its providers, but it doesn't do it for its patients and its families. So I think there are lots of opportunities to meet people where they are and to give them the kinds of tools that we already may have available. And a lot of that is built around creating a community, creating a social fabric, which we're currently missing. It's one of the things that's sort of, I never thought I was going to end up there, but when I was working on the book, and it's really fun it's the first book I've done like this. It's not just scientific, although I hope it's something in there is scientific, but it's a book of narratives. It's a book of stories about people I've met and experiences. And it ended up in a completely different place than where I had expected. I started the book, I think it was while I was at Google, with the idea that technology was going to fix the mental health crisis. And I ended up thinking that that's actually not going to work. But we could, but that by fixing the mental health crisis, we could fix a lot of other things in our society. We could fix the education system. We could fix the toxic world of social media, and if we did it right, we could actually build community in a way that's been sadly missing from modern life. And it was sort of the recognition that these 3 Ps weren't only important for that homeless guy on Skid Row. It's what we all need, right? It's what we all use and hope for in terms of not just recovery, but to thrive and flourish. And so why not make that a theme? Why not really use going after this brain health problem and make it a centerpiece for how we rebuild what some people would say is the soul of the nation, creating the community that so many of us feel is missing. Having said all that, sounds good, right? I was giving a presentation about this right after the book came out. It was my first book talk, and I was in San Francisco, and some guy came up afterwards. It's always like that, right? It's where I always have these epiphanies. And he said, you left out a P. I thought, well, you must mean prevention. He said, no. He said, payment. How are you going to pay for any of this? And that, of course, was exactly the point. And so that's how we got our current company going. He was the co-founder, we're both co-founders, of a company called Vana Health, which is taking what's in the book and saying, let's figure out a payment model. It turns out that for those people in that serious mental illness bucket, that second bucket that I mentioned, we spend a ton of money on them. In the markets that we're in, $50,000, $60,000, $70,000 a year goes into their care, and the results are terrible. And as he's pointed out, for $70,000, we could hire a full-time concierge coach for this person who could live with them and provide the housing for both of them. So that's basically what we do. We've figured out that by taking on risk, taking on these most expensive patients, and providing the 3 Ps at a much lower price, we have a pretty good business, and we do a lot of really good things for people who have been incarcerated and homeless and very badly treated by the healthcare system. And it's because they're really victims of a system that's totally focused and incentivized on them getting sick and being in the emergency room and being in the hospital and just being on that hamster wheel. Very, very expensive, very intensive, and really ineffective. So there's a better way to do it.
Bill Strong. So I'd love for you, we've got some people here involved in the justice system. Talk to us about the justice system and why it's become the treatments that, where many people that do have mental illness problems go, but also some of the mental illness that comes because of our prison systems. Where have you seen some good models for people involved in the justice system?
Yeah, well, there's a lot of interest right now in trying to figure out how to keep people out of jail. But the sad reality is that if you have serious mental illness, particularly if you're a person of color, and particularly if you're male, and especially if you're over 6 feet tall, you're probably going to end up in jail, not in the healthcare system. Just as kind of a brutal fact, there are in the United States, for public mental health beds, like in the old state hospital model, we have only about 35,000 beds at this point. And on any given night, we have about 360,000 people with serious mental illness in our jails and prisons. So it's a 10-to-1 kind of ratio. That's not true, by the way, in any other country. We're pretty exceptional that way. And it's simply because we don't have the capacity. It's a big problem. We had about 600,000 beds when I started my career in the state hospital system, but all of those were shut down in the 1980s and 90s, and they were never replaced. There's been replaced a little bit by private hospitals, which work okay if you have insurance, good insurance, but Medicaid by law is not able to pay for hospital care. So if you're in the public system or you're uninsured, which is usually the case for people with serious mental illness, yeah, you're going to be in the criminal justice system, not in the healthcare system. So isn't that incredible? I mean, it's hard to believe. It's one of the things that I keep thinking, speaking of grandchildren, I keep worrying about the day when my grandchildren are going to say, you really did that? Like, what were you thinking? It's like, we say that about Jim Crow today. It's like, what were you thinking? And like Jim Crow, I mean, it's this sense we have that, it's just the way things are, and that's just, we don't think about changing it. And yet it is pretty outrageous.
It's time to make a new normal.
Yeah.
a new normal that we've normalized it and we've got to change it. And now's the good opportunity for us. I see Steve standing up to try to ask some questions from the audience here. I know that many of you have burning questions, so I'd love to hear your questions from Dr. Insel.
So that, and I'm going to think about a question, but I am going to ask you to keep the question brief so we can get to as many. But we do have a combo question from the virtual audience that I thought was very interesting, because you talked about the fact that without a CPT code, it's hard to look at it from a healthcare reimbursement model. But I recall from our discussion earlier, maybe it's a cost savings model that you get reimbursed later. Do you see that as a possibility with brain health from a prevention standpoint? If you could explain to our audience what that model is.
Yeah, so thanks, Steve. The conventional model in healthcare is you get paid for services rendered, fee for service, and that usually means you get paid a lot if you're a gastroenterologist doing colonoscopies. If you have procedures, that's what you get paid for. That's how medicine works today. There's a different model, and that different model is to say, you provide care to a population and you get paid based on that population, based on outcomes. So you could say, well, instead of getting paid for failure when somebody's sick, you get paid for success because somebody doesn't get sick. And that's called value-based care. So value-based care, as opposed to volume-based care, value-based care means you're going to get a certain amount of money based on keeping somebody healthy or based on some sort of an outcome and this is being done, in orthopedics, it's been done in renal disease, it's been done for obstetrics. The problem in mental health, and this is for you, Sandy, is super important related to what you're working on here, is we haven't been very good at defining value. And so it's been difficult for payers to say, oh yeah, if you want to take on this population and go at risk, we'll pay you X dollars for these results. But nobody agrees on what the results are. Now you have a very interesting metric, right? The Brain Health Index. And those are things that, I think as the evidence accumulates, become really powerful for changing not only the science, but changing the payment models. And again, remember what I said is that in America, unless you can change the payment model, you don't change the practice here. So we have to think about that, and having a good definition of outcomes and a good way of measuring value is going to be critical as we go forward.
All right. Another question over here, Doctor.
So, picking on your neuroscience part of things, where do you see the testing or preventative or predictive model from some objective testing rather than subjective testing that we see?
Yeah, there's in most of medicine we have biomarkers that are really helpful. And I spent a lot of time and money and sweat equity on this when I was in the government at NIMH trying to create models based on neuroimaging, which is very powerful now, but will never scale. It's too expensive. Based on EEG, which might be feasible as an objective measure, but has a lot of variation, and it's not yet scaled. We're still using machine learning to learn what those signals are that matter. I think the more interesting part of it now, and I didn't understand this when I was at NIMH, but it's become really clear in the startup world, is that we can develop very objective measures of behavior and cognition. And we can get good numbers. Today we have ways of taking language. I mean, that's a lot of what happens in the mental health world is this conversation. And we have a way of called natural language processing, of actually understanding both speech and voice in a way that's highly objective. So you can measure things like sentiment and coherence and grandiosity and a bunch of things that we care about in the mental health world with great precision, even with just a couple of minutes of conversation. These are very powerful. And so these are still not, they're not available yet as clinical tools, but I think they will become available as clinical tools, so we call them vocal biomarkers. And they're super interesting. I was just visiting with a company called Ellipsis in California that's been working on this for many years. And their data are really interesting, that with just even a couple of minutes of conversation with a provider, or even over the internet, they can get a lot of, they can collect a lot of data that is much more objective. Last thing about this is, you know, during the pandemic, mental health care has largely moved to be remote. You don't need an office anymore, so it's all done through telehealth. And what's pathetic is it's sort of throwing away 90% of the data that are there through a telehealth conversation. So my hope is that over the next 2 or 3 years, we'll move to telehealth 2.0, where we'll start to bring in those kinds of objective biomarkers. And some of them can be around speech, some around voice, some even around facial expressions, which we can pick up on Zoom with incredible precision, and begin to add that to the subjective, because the subjective is really important, but we wouldn't settle for that in cardiology or diabetes care. I don't think we'd want to settle for it here either.
Hi, my husband and I are parents of a almost 4-year-old, and among our group of friends, especially those that have middle schoolers, the topic of social media, when to allow children to have phones, seems to be just so frequent and common. And I was just curious if you had any resources for us to help balance that, you know, allowing the social media and technology with, you know, making sure that it's not impeding or causing any sort of harm.
Wow, this is a great question. And it's, yeah, I'll let Sandy respond as well. I can't help but tell you this, that, so I had a period of my life when I was in Silicon Valley, surrounded by people who were running some of these very large companies, and they mostly had young kids, and they would never let their kids on any of this stuff. So, just as a, you know, consideration in thinking about how to approach this, I've been incredibly unsuccessful with my own grandchildren in keeping them. It's so addictive, and part of the problem is that my children are on their devices as well, so it's pretty hard to keep the grandchildren away. But Sandy, do you have thoughts about like how to manage social media?
Yeah, so we say, you know, is technology good or bad for the brain? And we say, yes, it is. You know, it's not a babysitter, but you really do have to look at what they're doing on it. When there's creativity and things going on and speed, there are some good things, but it really is overseen. It's just like, can you just go outside and run wild and crazy all the time in sports? No. Kids are jumping on top of cars and doing all sorts. Why do we not think that the young mind can decide what's good? So teaching them to vet, and that's actually what our training program teaches middle schools in particular, is where it gets dangerous, is they don't know, is this safe or not safe? So it is part of what we do to make people brain healthy, but not to say technology's bad. Technology is not an evil, but it's how we use it that makes it evil. And the social media, so it really is monitoring it and knowing.
Yeah, I think there's, and I've watched sometimes when the kids play Roblox with friends, you know, in the neighborhood, and you know, it's actually kind of wonderful to listen in, and they're really deeply engaged with each other.
But it's also addictive.
But the problem is, exactly this. It's the amount. It's like, and even if they were out riding their bikes with their friends, doing it this much is a little crazy. So it's figuring out how do you limit it, and when it, you know, like any addiction, it's so powerful. I mean, so you get temper tantrums, you get all kinds of power struggles around it. You know, the easy advice is to say don't let it start, but there's no stopping it. So it's, you know, I don't have a good answer for that.
But it is teaching them other things to do that are more fun. It's like put it away for 30 minutes and let's go do, and just divert their attention. That's what we do with any type of addiction, is divert their attention, and all of a sudden that's more fun. So you really do have to be creative.
Circling back to the value-based reimbursement initial question. Oh, sorry. So circling back to the first question, it was striking to me when you were talking about vaccines as being the one kind of preventative measure within the current sick-based healthcare system, because what you're describing, teaching kids about emotion regulation, et cetera, those are psychological inoculations. And one could even argue that an individual level psychological inoculation is a societal level inoculation for lots of unfortunate outcomes. And so I'm wondering if you think that there's any way to kind of take that angle, and if that could kind of fit into our current system, like, just thinking about how it is now, like if what you're talking about could kind of fit in from an inoculation point of view, like analogous to vaccines.
Yeah, so again, we should both speak to this. I mean, there is value in branding it in that way. I think the problem here is that a lot of what we're talking about is taking place in the school system and not in a clinic. And it's not being administered by a healthcare professional. It's really not healthcare in the way we think about it. So it doesn't, what I'm trying to get at, and the problem I'm struggling with, is we have a $4 trillion healthcare system in America. And yet all of the organizations, whether it's schools or community-based organizations or clubhouses, all of those organizations that provide the 3 Ps, they hold bake sales to stay open, right? They're not part of that huge, massive budget that is driving the whole insurance, public and private healthcare system. So we've got to figure out a way to fix that. And I haven't figured it out. I think the value-based approach is probably one of the ways to do it. And then you get a pot of money, and then you can spend it in the schools, you can spend it in a clubhouse, you can spend it in all kinds of places. Sandy, what's your thought?
No, I think you're absolutely right, is that it's hard, and when you talk about reimbursement, so that's why we're trying to define brainomics. What could be the economic benefit if each person from this year to this year either stays as brain healthy as they are now or better, that we could put a value on that? Then can we change public policy from that? And I think we can, but dollars do talk. But it's not sick care like what our healthcare system is, so we've still got a big conversation to undergo, and that may be okay. Maybe people don't need to go sick care, that we've got sick care and really health promotion, and especially brain health promotion, and that's reimbursed a different way.
Mm-hmm. Yeah, so I think and brain health has a kind of nice ring to it, right? Or you call it brain capital, however you want to frame it, in the sense that it both covers the healthcare system and so much more. So that may be the branding that we need here.
I have a question about the third P, purpose, and specifically with individuals 30 and under struggling with finding a sense of purpose. There have been multiple studies that show that organized religion is on a decline. Has there been research connected that you all are working on that shows with this decline in belief systems by way of organized religion, is that attributed to this loss of sense of purpose? Because oftentimes people that do follow a specific religious doctrine, they align their purpose with their faith. And so has there been any research that shows a correlation between the two?
You may know more about this than I do.
Yeah, so when we define purpose, I think that faith plays a very strong role in it. But we also want people to know that purpose, if you think about what our faith is, it's caring about the other person, someone bigger than you, and even some of the things you were saying, when people in these clubhouses, I wouldn't help, I helped somebody else. That's purpose. So we define purpose from that, and as we're taking it as part of our index and helping people realize that when you have a purpose every single day that someone's counting on you and it matters, your brain changes, and we teach them about the neuropharmacy that happens when you do that to make it healthier. You learn better, you sleep better. It's like, whoa, it's better than getting diagnosed with something. So for us, purpose is that my life matters today. The quality, not to see purpose and not really know, I can't feel it, you can feel it. Like those kids that you were talking about, when they're helping, they feel their purpose. They matter. And that's really what we try to do. It's even in the justice system. We want people, your life matters. And when it begins to matter, then they think, there's things I can do to make my life better. So purpose changes the brain in a very significant way that we never thought possible.
Yeah, I love that. And I guess the only thing I would add is I think part of the therapeutic potential of faith is being part of a faith-based community. And that it gets back to this need for community that is so missing in much of the nation right now. And that's, Sandy and I were talking before about what it's like for people in the military. The military provides a lot of that as well. Particularly, oddly enough, we did a huge study with DOD when I was in Washington to try to understand why there was so much suicide in the military. And what we discovered was, we thought it was during the Afghan war. We assumed it was due to the trauma of being in battle. Not at all. That was actually protective. When people went downrange, they had very, very low rates of suicide or suicidal thoughts. They were like in the mission, and they had their brothers and sisters around all the time. It was when they came back, and suddenly they had no purpose, and suddenly they had no battle buddies. They had nobody around them. And then then it was like, what's the point? And that's why so many of them re-enlisted to go back. And I think the faith-based community serves the same kind of need for that social support. It has the 3 Ps built into it. And so it's a great opportunity to rebuild around that.
One last question over here.
Hi, thank you. I wanted to ask about the challenges and opportunities in terms of maintaining brain health. In terms of the connection of or with chronic traumatic encephalopathy and other physical trauma-based brain diseases and traumatic brain injuries. And I'll just mention one challenge that I can think of, and that is we certainly know that physical activity, physical exertion is obviously very important for maintaining brain health. And we encourage everyone to be physically active, including kids. But we also know more and more that collision sports and other high-impact sports, like some of the most popular sports in the country and the world, football, American and international, soccer, and rugby, they can cause traumatic brain injuries, both concussive blows and repeated subconcussive blows. That's just one challenge. You also mentioned the military. Obviously, there's a lot of concussive effects, concussive forces involved in firing weapons. So I'd just like to mention that subject and see what you think about challenges and opportunities.
Yeah, so this is a great area to talk about brain health and its interaction with cognition and mood and the entire area. This is one of those areas that really overlaps between what's happening in the cortex, maybe even below the cortex, and what's happening with the way people, with depression and a range of other mood and PTSD issues. I don't have a great answer in terms of, I don't think we fully understand that those mechanisms. The epidemiological data are really clear that having a history of concussive episodes puts you at risk, not only for cognitive decline, but for a whole series of mood disorders as well. A lot of people are talking about that this week because of Senator Fetterman's story about having a stroke and now being hospitalized for depression, very common with left-sided strokes, which is what he had. So I think there's a story we've known for a long time about this overlap. It's when I was in training, people used to say, what's the difference between neurology and psychiatry? And they would say, there are 2 fields fighting over a common organ. And it's kind of like that. It's because it is still one organ, and the symptoms manifest on both sides. Sandy's an expert on this, though, so I shouldn't take her.
Yeah, and I'm not going to answer it long because I have a long answer for it. Because I've been doing research in traumatic brain injury for almost 25 years, and we know that there can be later emerging cognitive deficits, mental health deficits, and we've shown, regardless of how far out it is, when you teach someone the tools to use the brain, and a lot of it's stopping doing some of the toxic behaviors that make it worse. So we sometimes attribute it all to the concussion, but when you look at lifestyle and some of the things they're doing, not sleeping, addictions, different things, it makes it unhealthy. So we've been able to show brain repair 20 years afterwards in very significant ways, central executive networks, but also depression reducing by 60%, stress by 40%, but their agility and thinking significantly improved. So you learn to use this just like you do your muscle, but we think, oh, it's the brain injury. So you live with the diagnosis versus think, yes, I've had a brain injury. What can I do to make myself better year by year?
So I'm glad we ended on a high note, right? Because there was some heavy stuff there.
That can't be the last.
So, well, I think we're out of time.
One more question. Okay.
I'm not going to say no to my boss.
No, I've got to ask. So he gave away billions, trillions of dollars. I want to know if he was a DARPA and he could now do anything he wanted with $1 gazillion to improve where we are, what's the one big thing that you would dream to do? DARPA-like, change the world. You said we spent it on this, and now you've got a chance to really do something bold.
Yeah, you know what's so interesting? I don't think it's anything bold that we need to do. It's boring stuff, honestly. So what I think is going to be most important is just taking what we know and beginning to do it well. And that's, in a way, that's a very hopeful note.
See, you're recovering, Tom. That's good. And on a high note, that is. It's true. And we talk about that, right? It's not rocket science, but it is neuroscience. Simple steps make a big, big difference, and that goes to our conversation beforehand, so that is absolutely true. Your brain stays plastic throughout life. You can change it for the good, or you can change it for the bad. So let's change it for the good. So again, thank you, Dr. Insel. Obviously, thank you, Dr. Chapman.
Thank you.
Thank you to the Container Store for sponsoring tonight. Thank you very much. We can't do it without you. And here's a special treat. A local bookseller in Terabang Books has collaborated with us to develop a curated list of books about brain health, featuring Dr. Insel and others. So next week, we'll be emailing you this list. And remember, follow us on the website. Sign up for activities. I learn every time we do this, so thank you very much. And I think we ended on a high note. Thank you. Good night.
Good.